Thank you for all the love and support you're giving to my channel. Today I'm going to take you into the magical world of vascular surgery, which deals with the transport system of your body, your arteries and veins.
The heart is a pump.
Right.
So cardiac surgeons essentially deal with pumps.
Right.
If I'm a vascular surgeon, I deal with the pipes.
You deal with the pipes. Okay.
And arterial blocks and venous blocks are completely different.
Okay.
One is familiar with heart disease.
Mm-hmm.
And everybody knows about the heart because
Right.
the heart and the brain, they are emotive organs.
Right.
They're important organs.
Right.
Blood vessels are seen as less important. And that's why awareness about vascular disease is not great. You're familiar with the term heart attack.
Yes.
You're familiar with the term stroke.
Most of us are.
Yes. So a stroke is a brain attack.
Right.
A heart attack is when there is that significant narrowing of a blood vessel to the heart
Right.
and a section of the heart dies.
Right.
What you're seeing in diabetes is a foot attack.
It's a foot attack.
Vascular surgeon Ghostbusters.
Ghostbusters. Wow. That should be your tagline.
It is.
Oh,
It is.
okay.
Who are you going to call?
We are going to call
Ghostbusters.
Ghostbusters.
So vascular surgeons really underpin services in hospitals. Whenever there is bleeding, who do you call? You call a vascular surgeon.
Right.
Yes.
Hello and welcome to another episode of The Health Talk with me, your host, Dr. Sagorika Malik. Today, we will deep dive into the intricate world of vascular surgery, a specialty that deals with your body's vital highway system, that is your blood vessels. While many of us would worry about heart health, we often overlook the crucial network of arteries and veins that keep our bodies functioning. Joining us today is my dear friend, Dr. Arun Fairwani, a senior vascular surgeon who will help us understand everything from those visible varicose veins to life-threatening conditions affecting our circulation. So, whether you're a diabetic having leg pains while walking or simply curious about artery or vein health, today's episode will open your eyes to this fascinating field of medicine. Professor Arun Fairwani is Honorary Professor at Keele University School of Medicine and Consultant Vascular Surgeon at the University Hospitals of the North Midlands NHS Trust. He qualified from the Grant Medical College, Mumbai and trained in Bombay in general surgery at Sajeji Group of Hospitals. He pursued his higher surgical training in vascular surgery in Northern Ireland. He is a fellow of the Royal College of Surgeons of England and Ireland. He is also the director of the Staffordshire and South Cheshire Aortic Aneurysm Screening Program since 2013. In his spare time, he maintains a keen interest in health and fitness and over the years has had several interests including mountaineering, tennis and road cycling. In this episode, you will feel his passion and enthusiasm in helping his patients, especially small children. And after listening to this episode, you will be amazed to learn in how many ways a vascular surgeon can be of help to us. No wonder he calls himself the Ghostbuster. I feel extremely privileged to talk to my friend Dr. Arun Fairwani, and even I have picked up a few practical tips from him. Welcome, Arun, to the Health Talk.
Thank you very much.
So, Arun, can you basically start with explaining us, because many times we see that people confuse vascular surgery with heart surgery or heart health. So, what is it that exactly vascular surgery deals with or a vascular surgeon deals with?
That's a really good question. The heart is a pump.
Right.
So cardiac surgeons essentially deal with pumps.
Right.
If I'm a vascular surgeon, I deal with the pipes.
You deal with the pipes. Okay.
Yes. So I'm nothing more than a glorified plumber.
What?
It's true.
Right.
That's what we deal with. You talked about it yourself. This is the intricate highway. There's over 26,000 miles, actually.
26,000 miles.
Of blood vessels in the body when you add all the capillaries and everything else. That's it.
Right.
And what we deal with are the larger and sometimes the smaller blood vessels.
Right.
Beginning with the aorta, the main tube that comes out of the heart, works its way around the top of the chest, down through the chest, into the belly, and then breaks up around the belly button into the iliac arteries that are heading towards the pelvis and the groin, and so on as you go into the legs. There's also blood vessels that go into the arm. Arteries are blood vessels that go from the heart to the little finger or the big toe.
Right.
And veins are the blood vessels that bring the blood back to the heart.
So both are equally important.
They are, because one can't survive without one another.
Right.
And as it is with every highway, there's a way there, but there also needs to be a way back home.
There needs to be a way back home. Very true. So, okay, these are the blood vessels. So what exactly goes wrong with the blood vessels? I mean, why do we need a vascular surgeon?
You do. Because why do you need a plumber? You get blockages.
Right.
Yes, the drains don't work.
Okay.
It's the same sort of thing. Vascular pathology is different.
See, people understand what is heart arterial blocks.
They do.
Similarly, are there other blocks in the arteries, other places?
Correct. And arterial blocks and venous blocks are completely different.
Okay.
One is familiar with heart disease. And everybody knows about the heart, because the heart and the brain, they are emotive organs.
Right.
They're important organs.
Right.
Blood vessels are seen as less important. And that's why awareness about vascular disease is not great. The other issue with vascular disease is generally affects older people. And if you know, when you and I went to medical school 30 years ago, 40 years ago, the average lifespan of an Indian male was barely 60, 62.
Right.
Aortic aneurysm screening begins at the age of 65.
What is an aneurysm?
It's swelling of a blood vessel. A blood vessel should look like this. An aneurysm looks like this. It's as simple as that.
Okay.
And so it's traditionally seen as a condition of older people, but as I'll explain, it's seen in younger patients as well.
Okay.
Fundamentally, the difference between arterial disease and venous disease is arterial disease is a generalized process. It has the same risk factors that heart attacks do.
Okay.
So, male gender.
All right.
Family history.
Right.
You can't change those.
Right.
What you can change, cigarette smoking.
Right.
High blood pressure.
Okay.
Cholesterol.
Okay.
Diabetes.
Right.
So there are the modifiable and the non-modifiable risk factors for vascular surgery. You cannot change your gender, not easily, and you cannot change your genetics, but you can modify diet.
Yes.
You can stop smoking.
Yes.
You can reverse, cure diabetes and treat it when it's in an advanced stage. You can treat blood pressure.
True.
And one can treat high cholesterol.
Absolutely.
Yeah. Venous disease, on the other hand, is vascular bed specific. In other words, it occurs in certain areas of the body.
Yes.
The fundamental difference between us as humans and every other mammal is we are the only mammal who have the ability to stand on two legs.
Right.
All other mammals are on all fours.
Right.
When we're standing, there is tremendous pressure in the veins in our leg. That's the static column of blood pressure, of pressure in a tube, and gravity.
Right.
When we use our calf muscles, that's the pump that pushes the blood back to the heart. And veins have valves that open in one direction only.
Okay.
When these valves are damaged, particularly in the lower leg or in the groin, then one can get varicose veins. If one has a clot in the deep veins of the leg, a DVT, that damages the valves. Those veins then stop allowing blood to go in one direction only. So there's high pressure in the veins, and that can cause varicose veins.
Right.
There are conditions in young people, particularly young men who do a lot of gym work, athletic, a lot of bodybuilders, and they can get narrowing of the vein as it enters the chest.
Narrowing?
Yes, from repetitive movements of the shoulder and the arm.
Okay.
And that can cause a DVT, a clot in the arm.
Okay.
Conditions that essentially predict sticky blood. So there are inherited conditions, factor V, Leiden, prothrombin. We didn't know much about these in the past. The research around this was very active in the 1990s.
Okay.
And those conditions suggest that one has an inherited tendency to form clots. Okay. When you add that condition to something environmental, for example, a lady who's on an oral contraceptive pill, or pregnancy with twins or triplets, or somebody who has an operation and they don't move.
Right.
Then that risks a DVT in the lower leg. Or the worst sort of venous thrombosis, which is venous thrombosis that affects the blood vessels in the brain, dural sinus thrombosis. So there's always something genetic and something environmental that combines together to predict venous diseases. Arterial diseases are more generalized. So the same narrowing that affects the blood vessels to the heart, causes angina or heart attack,
right,
also affects the blood vessels to the brain, the carotid arteries in the neck.
Right.
And that can cause minor strokes, TIAs,
right,
amaurosis fugax, which is a curtain coming over the eye, temporary blindness,
okay,
or a stroke.
Right.
It can cause narrowing of the blood vessels to the kidney. That releases hormones that increase the blood pressure, renovascular hypertension.
Right.
It can cause narrowing of the blood vessels in the legs.
Mm-hmm.
And that will give rise to a condition called intermittent claudication.
Right.
So when people start walking, they walk a few hundred yards, they start getting pain. Either in the calf or in the thighs and the buttock. And that predicts where the narrowings are.
Okay, the time you mean to say.
So when one has essentially pain in the calf, then the narrowing tends to be one level above. So in the groin and the arteries in the thigh. When one has pain in the buttock and the thighs when walking, then the narrowings could be in the aorta, that's the main tube, or the iliac arteries, the belly button down. Also, conditions such as spinal narrowing, spinal stenosis, can also give similar symptoms. So distinguishing between vascular claudication and spinal claudication is important. We don't really need to go into the spinal stuff.
Right. So, Arun, as we were talking, and you said something about varicose veins, and in India, it's a very common problem which we see. But the problem is, most of my patients, when I tell them that you need to do something about it, they say, "Doctor, it's nothing is seen. Why do we need to do something about it?" So they think it's only cosmetic, but I'm sure it has got health reasons, or it can lead to health problems. So, can you talk something more about that?
Sure. Your patients are right. And over the years, one thing I've learned is I listen to patients.
Oh, great.
They are correct. A lot of varicose veins are entirely cosmetic.
Okay.
So can they be left alone? Yes, some can. You can't predict which ones will give trouble, though. That's the issue.
Right.
So one of the things to look out for is make sure they're not getting worse. And enlargement in size. They can cause symptoms. So most common symptoms is a heaviness in the leg, particularly at the end of the day.
Right.
Okay. And very simple measures treat that. That's elevation at night.
Yeah, but then, see, why I'm asking you is important is because a lot of my patients are housewives who are working whole day standing.
That's right.
And they generally tend to neglect their health.
They do. Women in India always do that. When there's anything wrong, it's always the men who get treated first. When anything happens to a lady, it's neglected.
So
not by them, by them and by the entire family as well.
Absolutely.
So one of the issues is, so if you are in the UK...
So we want to err on the safer side.
If you're in the UK, if you're in colder climates, then one of the things we suggest people use are a pair of compression stockings.
Right.
That's often very useful.
We do use that.
Yes. So it's easier to wear compression stockings if you're in an environment which is cold. So if they are in the house and the houses are air conditioned and they don't feel particularly hot, then yes, wearing a pair of compression stockings. It can be as simple as a pair of support tights, flight socks, or even surgical grade 1 compression stockings. And it doesn't have to be long leg ones. They could be even up to the knee.
All right.
Yes.
Okay.
The important thing to do is to lie in bed, put the legs up, get the swelling down, put the stockings on, and then leave them on all day. As you say, they're on their feet, they're in the kitchen, they're doing all this stuff for everyone else. The last thing they do at night before they go to bed, if they bathe and shower and everything else, take the stockings off and then keep the legs elevated at night.
Okay.
Now, how does one do that? Consistently, reliably. Very often, if one just puts a pillow under the feet, all you do is you kick it away and you sleep.
Exactly.
Yes. So there needs to be something under the mattress. So if you roll a duvet, put it under the mattress, lift the mattress up, or a couple of blocks under the foot end of the bed.
Right.
That elevates the legs. It does two things. It helps venous return.
Right.
It reduces the swelling in the legs. And it helps tremendously with the discomfort and the pain in the legs that people get.
Right.
And in the morning, the first thing they do is they wear stockings. What we tell our patients in the UK is ideally do your shower and bathing and everything else in the night rather than in the morning. So the first thing you do before you get out of bed is you wear your stockings.
Right.
In India, things are customarily different. People like to bathe in the mornings. They like to pray and everything else. So it's important to go back into bed, lie in there for about 20 minutes or so, keep the legs elevated, then put the stockings on and leave them on all day. These practical tips are extremely important.
Right.
Now, varicose veins, if they've had DVT, etc. in the past.
1 second. Before you continue, when you talked about elevation of legs, I just wanted to ask you because, again, one thing, though it's not related, but it is very common in India about ladies having anemia.
Yes.
And they have a lot of swelling in their legs. So does this, the thing what you said about elevation of it, I'm sure it will be helping that also?
It helps swelling that is associated with anemia. It helps swelling that's associated with heart failure. It helps restless legs in patients who are diabetic and have an element of neuropathy. It helps swelling in the legs that you see in hypertensives who are taking drugs like amlodipine.
Right.
So elevation of the legs, particularly above the level of the heart, is useful for several conditions.
Right. Sorry to interrupt you.
No, that's fine.
Please.
So then there are varicose veins that can cause skin damage. And that's the one that concerns me. Because once the skin's damaged, then fundamentally that can lead to ulceration.
Right.
An ulcer is a break in the skin. As we remember, the definition from 40 years ago of an ulcer still stands today.
Right.
It's a break in the skin or the mucous membrane. The mucous membrane, for example, the inside of the mouth, or the inside lining of the stomach. You know, you're familiar with gastric duodenal ulcers, or an ulcer in the leg. So these are because of high pressure in the veins. Once there is high pressure in the veins, there's leakage of blood and blood products out of the veins.
Right.
That protein leakage out of the veins causes that the soft, supple tissues of the leg are replaced by the hard, thickened skin.
Right.
The discoloration comes from the breakdown of blood cells. Blood cells break into chemicals such as bilirubin and biliverdin. You're familiar with them in terms of liver pathology.
Right.
And those will cause discoloration. The iron breaks into an element called hemosiderin. That hemosiderin deposition will give you discoloration and pigmentation. So the legs get discolored. Once that happens, it's impossible to reverse. So these changes are permanent.
Okay.
So that's why elevation, treating patients well beforehand, is a good idea. These simple measures go a long way in stopping. Elevation and compression will stop a lot of the progression of varicose veins.
Right.
Once they've got pigmentation, hemosiderin deposition, lack of blood supply from the small blood vessels to the areas of the skin, then minor trauma, minor injuries can precipitate development of an ulcer. And then the ulcers are very difficult to heal because fundamentally the ulcers also require the same treatment. They require elevation and compression. But the compression there has to be a lot more significant. So compression bandaging or greater levels of compression, grade 2 compression, for example, or grade 3 if you want an ulcer to heal and stay healed. There, of course, the greater the level of compression, the more difficult and uncomfortable the stockings are.
Absolutely.
And people don't like that, particularly in warm climates.
Right.
So you're into a vicious circle.
Right.
Of course, these veins can be treated. There are trials that have suggested that treating patients with compression bandaging, stockings, and treating the varicose veins with either laser or heat to essentially fry the inside lining of the veins and cause the veins to thrombose, clot off. The modern methods of treating varicose veins are equally as effective and improve the ulcer healing rates and allow the ulcers to stay healed. Previous traditional old operations involved stripping of the veins, ripping them out from little holes in the groin and in the legs and little cuts in the legs to take as many veins out. But there are modern methods. We talked about two, using laser or heat to fry the veins. There's also chemical ablation.
Right.
So the use of chemical agents along with air that's mixed together forms a foam that encourages the vein to then clot off. Thrombose. And there are variations of the thing.
No, but initially, Arun, you said that, my patients are correct in saying it's a cosmetic. But once you reach these levels, you have to treat them.
In an ideal world, yes. Yes, because you
But
want
you said in an ideal world, what happens if you don't?
If you don't, they can progress to ulceration, and then it's very difficult to treat. Also very expensive, because the costs of dressings, ulcers, cost of treating ulceration, cost of antibiotic therapy, cost of repeated hospital visits, seeing different practitioners, seeing nurse practitioners,
right.
All of those costs add up. And when patients are self-paying particularly, then one has to consider these.
And then it leads to a lot of pain also?
Yes, indeed. Ulceration can be painful with varicose veins. Rarely so, but yes. Generally, when there's a pain with an ulcer, general rule of thumb is it tends to be an arterial ulcer.
Right. So then let's talk about arterial ulcer, which happens in a diabetic foot, I suppose.
Very good.
Right. So
very good.
I mean, because I also deal with a lot of diabetes patients, and they come with diabetic foots or diabetic ulcers, which we say. So can you talk something more about that?
You're familiar with the term heart attack?
Yes.
You're familiar with the term stroke?
Most of us are.
Yes.
Even the common public, at least they've heard about it.
Indeed. So a stroke is a brain attack.
Right.
A heart attack is when there is that significant narrowing of a blood vessel to the heart.
Right.
And a section of the heart dies.
Right.
What you're seeing in diabetes is a foot attack.
Is a foot attack. Okay.
Yeah.
Basically, the blood supply stops.
Well, it's more than just the blood supply. Diabetes is an absolute killer.
Mm-hmm.
And the thing about the most effective killers are they are silent.
That's the sad part.
And diabetes is a silent killer. It is one of the most interesting diseases because, frankly, diabetes is curable. It is entirely curable simply by diet and weight loss.
Only in the early stages.
Absolutely. In a pre-diabetic stage or an early diabetic stage. Once there's established diabetes, unfortunately, the organs start getting affected by the high sugar levels.
Sure.
The eyes. They get retinopathy.
Right.
There's damage to the blood vessels at the back of the eyes and the retina.
Mm-hmm.
Diabetes affects the kidneys.
Right.
It causes diabetic nephrosclerosis. It predisposes patients to develop atherosclerotic disease, hardening of blood vessels.
Right.
Really. And the kidneys start failing. Diabetes increases the risk of heart disease, vascular disease. Promotes hardening of blood vessels in the heart and in the legs and in the arms as well. Renal patients who have diabetes with kidney failure, have absolutely awful lives, and their survival is less than somebody with stage 3 colonic cancer. 5-year survival of less than 50%. Indeed. Diabetes affects the blood vessels, as I said, by causing hardening of the larger blood vessels. But it affects the microcirculation, the small blood vessels that we can't see. So even when the large blood vessels are open going into the legs, the smaller blood vessels, the capillaries that go from the larger vessels to the toes get affected, and these are destroyed. So the microcirculation is destroyed. To that, you add the effect of diabetes on the nerves, the
neuropathies.
Yes. Classically, patients describe a glove and stocking distribution of neuropathy. So they lose sensation, feet,
right,
stockings,
hands. They'll come with tingling, numbness, not feeling well.
The first sense that is lost is the vibration sense. So using a tuning fork and then using the fine feathers to measure soft touch. Exactly. All of these features are features of diabetic neuropathy. Once a patient's reached that stage, these are irreversible. They're only going to get worse.
Right.
And the thing that predicts all of these is a raised HbA1c.
True.
So the only way to prevent diabetic complications is to cure the diabetes at an early stage. And the fundamental way of curing diabetes at an early stage is weight loss.
Absolutely.
Trials done, led by the Newcastle unit and mirrored across in the United States, have shown a fundamental target weight loss of 15 kilograms in diabetics and 10 kilograms in pre-diabetics to essentially reverse diabetes. And the eureka moment, when Archimedes ran out of the bath, stark naked, running across the street, he realized he'd had this landmark discovery. That was what bariatric surgery demonstrated.
Right.
10 days after bariatric surgery, when patients had that target weight loss of 10 kilograms, diabetes reversed. The fatty liver, fatty pancreas reversed, insulin resistance dropped.
Right.
Beta cells in the pancreas that produce insulin which were dormant, were revived. So the previous theories that the beta cells are dead are no longer true. These cells are revived, and patients can cure diabetes at an early stage. The most important thing is to maintain these diets. And essentially,
that's the underlying statement.
And that has to happen. There's a famous saying, it says, culture eats strategy and structure for breakfast. Culturally in India, we eat too much.
Yes.
We eat essentially carbohydrate. Everything that's to do with religion is to do with something sweet.
Right.
There are too many festivals.
True.
Too many gods.
True.
And too much sugar.
True. How do you stop diabetes?
Stop the sugar, stop the carbohydrate, and exercise. There is little culture around exercising, particularly in ladies, particularly in housewives. Classically, you look at middle-aged men in India, they represent lollipops, sticks like arms, sticks like legs, and a big belly. And it is thought in Indian culture that having a belly is a sign of prosperity. However, let me tell you, the wealth of the nation is inversely proportional to the size of the waistline. The wealthier, healthier people are thinner and are better preserved than people who are fat. It is common in India to say somebody is a little bit overweight. No, they're healthy.
Right.
And that fundamentally needs to change.
And that leads to many health problems.
Exactly. Here's another myth for you. Breakfast is the best meal of the day.
Yeah. Indians can't live without a breakfast.
And that's the problem. As a result of that, they die early.
They definitely develop diabetes at a much earlier age.
Life is quite simple when one understands. Everything is essentially carbon atoms. That's all we are. Glucose, 4 carbon atoms, fat, 8. So what do we eat? We eat protein, carbohydrate, too much of, and fat.
Very little of protein.
Whatever protein we eat, if we eat too much of it, that is converted to extra glucose. Glucose is stored in the form of glycogen, muscle and liver. When there's too much of it, that's converted to fat. Right. Simple, biochemistry, first year of medicine.
Right.
Fat. You eat fat, it's stored as fat.
Yes.
There's nothing else it can do. And the principle of ketone diets came from using fat. To use fat as a source of energy.
Right.
Glucose is extremely important because the brain can only use glucose.
That's right.
Particularly. And of course, carbohydrate, which we eat too much of in India, is also stored as carbohydrate. And excess carbohydrate is stored as fat.
That's fat.
It begins with storage around the belly. It's belly fat. But there's only so much belly fat one can have. And then it starts being stored inside the tummy, around the organs. And all of this is excess fat that we don't need.
Absolutely.
The body's really struggling because it's got so much fat that's transferred from glucose, from the fat we eat, the ghee, the butters, and all of these things.
Right.
All the extra protein. We go to the gym, protein shakes, but then you're eating as well.
Yes.
And all of this extra food is now being converted to fat. And when the body's fed up of storing all this fat, it starts getting stored in the organs, liver and pancreas.
Liver.
So you get something called fatty liver.
Yes.
Fibroscans.
Yes.
I'm a surgeon. I operate. I open the belly every single day. You can spot a fatty liver as soon as you open the belly. The edges of the liver are nice and sharp in youth. The edges of the liver, when people get bigger, fatter, are rounded. It's the simplest way of demonstrating fatty liver with a laparotomy on opening the belly. But you've got scans and everything else that tell you that. You don't need to open the belly to know that you have a fatty liver. And it's not just storing in the liver. There's a fatty pancreas as well. There's an absolutely fantastic book about living with diabetes and how can one cure diabetes. And it's extremely lucid and it's written in simple language. And it explains all of the studies that were done as well, including weight loss, how to maintain weight loss, how to cure diabetes, particularly at an early stage. We talked to you about diabetic drugs since we talked about diabetes.
Right.
So a lot of people take metformin. It's the first line of drug for diabetes.
Yes.
It has side effects.
Of course it does.
Every single drug has side effects.
Absolutely.
They tell you about the benefits. They don't tell you about the side effects, do they?
No, they don't.
Yes. And a lot of people in India take metformin for weight loss.
They do.
And a lot of people in Hollywood take metformin for weight loss. Every other diabetic drug thereafter puts weight on.
Right.
Second line agents, insulin.
Everything is weight.
Indeed.
You put on.
It's associated with weight gain. Insulin, growth hormone, testosterone are the anabolic hormones. Everything else are catabolic hormones. There you go. And of course, you've got the newer drugs now, which are the fad. Ozempic, Mounjaro, injectable, tablet, and everything else. they have huge side effects.
Of course.
They're extremely unpleasant drugs. Essentially what they're doing is all the food you're eating that's going through the stomach and the intestines, they're reducing transit time. My apologies. They're increasing transit time.
They're increasing. Yeah.
So
you feel full all the time.
Exactly. You feel full. When you overeat, you feel like throwing
up.
Exactly. They're miserable drugs. There are other beneficial effects that are being shown, but it's all associated with weight loss.
Yes.
Now, why does one need a drug to lose weight?
You don't actually.
There are simpler ways of losing weight, and that's fundamentally not eating as much. One doesn't need to have one's jaws wired shut, but one can consider some very healthy ways of eating. Firstly, eating what is a Mediterranean diet. So salads, nuts, tomatoes, etc.
Problem is they're not very tasty to the palate.
And again,
there's a lifestyle change which you need to make a decision.
Indeed.
Like, what's important to you?
So all palate is based on conditioning. Because we live in India, because we're brought up there, we're conditioned to have excess carbohydrate and excess sweet. No one has tea and coffee without sugar in it.
No one.
Yeah, I have black coffee. I don't find it bitter or terrible. I actually quite like it. If I have sugar in it, I find that nauseating.
Yes.
Conditioning.
Yes, conditioning. Yes. Absolutely.
So you can condition your palate accordingly. Blueberries, blackberries, strawberries, healthy fruit. Bananas, high calorie. You want to avoid them.
Yeah.
Yes, everyone has a banana milkshake and a smoothie. You got banana, milk, and sugar. Three of the worst things together. Do you know something else, Sagarika? We are the only mammal who continue to have milk beyond infancy.
Right.
Infants need milk. You and I don't need milk.
We don't.
That's right. We have teeth.
Yes.
Yes.
But not drinking milk it's considered as something drastically wrong. Why are you not drinking milk?
Well, I challenge such myths because drinking milk is drastically wrong for an adult.
Absolutely.
Yeah.
But if you tell that to a person, they're not happy to hear it.
Well, that's just terrible because fundamentally, if you want to reduce weight, you reduce milk and milk-associated products.
Absolutely.
Butter and cheese. Yes. So when we eat, what tends to happen is the blood glucose and glycogen levels go up. Glycogen, as we talked about, was stored in the muscle, stored in the liver. When one fasts, the basal metabolic rate and the function of the brain and all the organs in the body continues. That requires energy.
Absolutely.
That energy is drawn from glycogen stores. If you keep feeding the fire with more and more food, part of it will be used, the rest of it will be stored. And clearly we've seen we store far more than we use.
No.
That's why people become fat.
Right.
But if we stop storing as much, which means stop eating as much, then we will use a lot more, which is in our bodies.
Right.
So we use a bit of muscle glycogen. We then use the liver glycogen. We use the fat stores in the body.
True.
We burn fat to produce glucose that the brain needs. And that fat burning process leads to a degree of natural ketosis. So if you see a bit of ketones in the urine, that, especially when one is fasting, that's not wrong. That's actually quite healthy.
Yeah.
Well, you're quite right. It is healthy. The principle of fasting, therefore, comes in. And one doesn't have to fast ridiculously. We have people fasting in India on a Monday,
yes,
on a Tuesday, on a Wednesday, on a Thursday, on a Friday. Even Saturdays and Sundays, they're the God for every day of the week.
But if you tell them that you're fasting for a God, they don't mind.
They're very happy.
If they tell them that you do it for your health, no one wants to do it.
And that's really sad. That's really sad. And all one requires is intermittent fasting. So not eating for about 12, 14, 16 hours allows the body to start using one's own storage of fat and glycogen. And that promotes weight loss. In an ideal world, we don't need 3 meals a day. You skip breakfast, have something at midday, anywhere between 11 to 12 to 12:30, and have the next meal between 5 and 6 in the evening. That's absolutely perfect. You're not hungry, you're not starving, and then your next meal after 6 o'clock in the evening is the following day.
Right.
At about 10 or 11 or 12.
Right.
So it's not difficult to do 16 hours of fasting.
It's not. And the body can learn very easily.
Very easily. Have a glass of warm water in the morning.
Right.
If one is taking their medication, that's very easy to do. Have a black coffee or a cup of black tea. It's absolutely fine. It's got no calories. It does not promote glycogen storage.
Right.
And that's a simple way of reducing calorific intake, using one's own body stores for energy, curing diabetes and curing obesity.
Right.
Yes, one does not require the services of a bariatric surgeon.
But that's the easy way out. That's the easy way out.
Yes.
I mean, everybody will come and tell me, doctor, I'm not losing weight. Can you give me a pill for it?
Yeah.
Everything cannot have a pill. You have to work for it.
Indeed. And all of the weight loss trials, including tablets, injections, bariatric surgery, have demonstrated one thing. As soon as that period of supervision ends, patients go back to their way of eating and their way of life.
Absolutely.
And they put the weight back on.
Absolutely. That's where the diabetes comes back. So now, as we were talking about diabetic ulcers, in what way do you as a vascular surgeon can treat it?
That's very good. So when we talk about diabetic ulcers, I came back to, I'm sorry for digressing, but
no problem.
Diabetes, I've talked about it being a foot attack.
Right.
Here's when the elements have conspired to form a perfect storm where there's no feeling in the foot. So the foot and the toes are prone to minor trauma. If one stubs one's toe against the edge of a table or a chair, one screams out in pain. Diabetics can't feel it.
Can't feel it.
When one is cold, in cold countries, you stay close to a radiator or a fire and you feel warm. Diabetics can't feel it.
They may burn themselves.
They burn themselves. You're absolutely right. And then you've got minor tissue trauma. There's not enough blood coming there, so it doesn't heal. The tissues are laden with sugar. It's not us who just like sugar. Bugs love sugar.
Oh, they love sugar.
Indeed. So this becomes a fertile environment for bacteria, viruses, most importantly
fungus,
which are always present between the fingers and toes to attack these weak and defenseless tissues that we have. And there you go. That's diabetic feet. Here's another story. What's the most specialized structure in the human body? I ask this question all the time to my students, to patients, to a lot of people. A lot of people say it's the brain. Well, dolphins have brains. It's our ability to communicate. Whales communicate. It's our ability to do the opponent's maneuver. Eat with a knife and fork. Chimps and monkeys can do that too.
Right.
It's our feet.
It's our feet.
Indeed. Goes back to the point that we are the only mammal who can walk on 2 feet. And whatever size, shape, height, weight, age, body structure we are all capable of walking on those 2 same small feet. That's right. The reason we can, because the foot is made up of intricate structure of bones, ligaments.
Right.
That allow for the foot arches, for a heel to toe gait, where the weight of the body is transferred from the heel across the side of the foot, to the heads of the metatarsals and the gait. And you want to put one foot forward and another one. So the weight-bearing surfaces are around the heel and around the heads of the metatarsals.
Right.
When one has diabetes, they lose the ability to feel. They also have this autonomic neuropathy that destroys these muscles and ligaments in the feet. So one tends to develop a flat foot. And all these areas which normally take pressure have changed. So the biomechanics of the feet change entirely. One other thing. Today we're doing this interview. We're both wearing shoes and socks. If we took our shoes and socks off and touched our feet just now, then what we will find is our feet are warm.
Right.
They're sweaty.
They're sweaty.
Diabetics will have warm, dry feet. They lose the ability, because of the autonomic neuropathy, to sweat. All of these factors make the foot extremely prone to develop ulceration. As soon as there's ulceration and damage, and then infection, the infection goes to areas in the foot that are particularly vulnerable. Tips of the toes.
Right.
The metatarsophalangeal joints, the joints between the toes and the rest of the foot. And the areas of cartilage, the structure, the collagen that covers joints is often bereft of blood. So these areas particularly are prone to infection. Once these areas are infected, the only treatment is to chop them off. So a lot of what I do with diabetic feet are amputations.
Amputations.
That's right. Minor amputations and major amputations. Diabetic infection spreads along tendon sheets. So it can spread from the foot along the side of the ankle on both sides up the calf. When that happens, the inevitability is losing the leg either below the knee or more than likely above the knee. That's a lifetime of disability.
Absolutely.
And as soon as one loses one leg, one is at a greater risk of losing
the other one.
Part of what I do as a vascular surgeon is I used to run until last year the National Vascular Registry with colleagues. And it's the most fantastic source of information on outcomes for patients, and diabetic foot infections are a particular area of interest. What we were able to show is if one has a little toe or a second or a third toe, that predicts losing that leg. Every year, the risk of limb loss is between 10 and 20%. The risk of losing the opposite leg is also high. When one loses both legs above the knee, less than 50% of those patients are alive after 6 months. That is how severe diabetes, diabetic infections are. And the most important thing one can do is to prevent it.
You're right.
What vascular surgeons also do are attempts to bring more blood into the foot. So one can do operations such as bypass operations. I said to you at the beginning, I'm just a clever plumber. So when there is narrowing of blood vessels, for example, in the thigh, that causes a blockage, lack of blood coming to the calf, stops them from being able to walk. The best treatment for that is to stop smoking, control the diabetes, take the right tablets, aspirin, clopidogrel, bring the blood pressure down, and using statins to reduce cholesterol. And walking. Because what walking does is it encourages the muscle to adapt to lack of blood. It opens up collaterals, smaller blood vessels that are normally shut.
Right.
And in the long term, that gives them the best relief. In the short term, patients want a quick fix. So things like putting a balloon in the artery and stretching up and narrowing, or putting a stent in the artery and opening it out, or doing a bypass. But when it is done for earlier stages, they don't do as well as patients treating themselves. However, when it comes to a condition called critical limb-threatening ischemia, the word critical tells a story.
Right.
If we don't do anything at that stage, then patients are at risk of losing their legs, developing gangrene.
Right.
Diabetic foot infections are an example of gangrene.
Right.
Dry or wet gangrene, where there are areas of black mummified tissue or infected black wet
tissues.
That's right.
And then you'll end up with an amputation. 100%.
And they require certainly amputations of either toes, foot, legs. To prevent that, when one has pain at rest pain, or early ulcers, then doing operations or doing angioplasties, putting stents, and there's a lot of innovation today around using drug-eluting technology, the same technology that's used in stents in the heart, using new devices that can break bits of calcium, either with ultrasonic rays, or devices that can strip out a bit of calcium, or the traditional bypass using the vein from one's own leg.
Right.
All of these are designed to be able to bring more blood into areas of the leg and the foot which have less blood.
Hopefully so that those areas heal.
That these areas heal, and it prevents amputation. Along with that, it's very important that the lifestyle modification continues. So one cannot smoke ever again. One cannot use nicotine products.
Right.
Nicotine is one of the most powerful vasoconstrictors. Now it causes blood vessels shrink. That's right. So vaping is not safe necessarily.
Right, because nowadays the kids have started doing that.
And it's an absolutely awful thing. And the amount of nicotine in a disposable vape is enough to send somebody to the moon. They are extraordinarily high. You do not need muscles or a rocket to go to Mars. You just use one of these vapes, literally. They are horrible, horrible things. What we're seeing is a new range of respiratory illnesses.
Right.
And we will see the effects in terms of cardiovascular illnesses.
Maybe 10 years down the line,
Absolutely.
when these youngsters are reaching the 35, 40.
Absolutely. You're absolutely right. And that's what preventative medicine will tell you. It's studying the effects of these conditions on populations over decades.
Yes. The thing is, you always see the reaction after a decade, and then by that time you don't have anything to do. You have already damaged the whole system.
It's too late. Once
so
the
it's
damage
too late.
occurs, it's too late. It's to try to catch a disease at an early stage.
Much earlier stage.
Prevent it and prevent the complications. All we're doing at this stage is now treating the complications of hardening of blood vessels, the complications of diabetes. The time for cure is long gone. Now we're just managing complications. we're putting sticking plaster. This is Band-Aid.
Right.
This is not cure.
This is not cure. Also, there are many people who come with leg pain and they come to me and say, no, doctor, I walk for maybe 100 meters and I get the pain, and then again I walk for 500 meters and the pain goes off. So,
So this is what
medically,
classic manifestations of intermittent claudication.
Right.
Narrowing of blood vessels, exercise increases the blood flow to muscles. The narrowed blood vessel stops the muscles getting that bit of blood, so the muscles are crying out in pain. It's metabolism. We go back to biochemistry from first year in medicine that none of us really like. We've gone from an aerobic metabolism, where there's oxygen in blood, to anaerobic metabolism, where there is production of lactic acid, and therefore it's painful. And when they rest, it allows the circulation to catch up and they can go again. That is the stage where risk factor modification, weight loss, smoking cessation, treat the diabetes, best medical therapy, which is a combination of antiplatelet agents, aspirin or clopidogrel, blood pressure modification, drugs like ramipril, amlodipine, etc., and the use of statins, atorvastatin, rosuvastatin, and their combinations, etc., along with exercise. What tends to happen then is, over a period of time, with consistent exercise, patients are able to double the distance they can walk. So your patients will go from 100 meters to 200 meters to 300 meters to longer. More importantly, we are reducing the cardiovascular risk for these patients. A, they're exercising. Right. B, the tablets, as we said, arterial disease is a systemic process.
Right.
The same narrowing is affecting the coronary arteries in the heart. The same narrowing is affecting the carotid arteries in the brain. So you're reducing their risk of heart attack, stroke, and death. What we know from trials in the late 90s and the early 2000s is all of these drugs reduce the risk of heart attack, stroke, and death by approximately 25%. What we do not know is whether a combination of drugs reduces the risk of heart attack, stroke, and death by 75%.
75%.
We do not know that.
Oh.
But we do not have that degree of cumulative effect.
Right. 25% reduction
is a significant reduction. It is a significant reduction. Out of 4 people, you're stopping a heart attack in 1 person.
Yes.
At least. That's
a great outcome.
Fundamentally, it comes down to lifestyle modification, appropriate drug therapy, and maintaining that. I think that is where people go wrong. These tablets, this lifestyle change is for the rest of your life.
For the rest of your life.
It's not temporary.
Right. That is where people go wrong. I've done it for 6 months, 1 year, I've lost my weight, and then I can go back to my original lifestyle.
And as they're doing that, vascular disease is only progressing. Silently, quietly, killing them from the inside.
So, veins and arteries by itself are very small.
Indeed.
And then we now hear minimally invasive procedures about, and you being a vascular surgeon. Why don't you tell us something about how they help or in what conditions they help?
Yeah, very good. We talked a little bit about minimally invasive procedures for varicose veins. So rather than the old-fashioned cutting the groin and the stripping, there's use of laser or electricity or heat to essentially fry the inside of the vein.
Right.
Minimally invasive day case procedures. Rather than a long bypass under an anesthetic in a leg, harvesting the vein from one's own leg, turning it upside down and connecting 2 ends of a pipe together. One can open the blockages in the pipes with minimally invasive techniques. So using balloons or stents. Balloons to stretch an artery, a stent to keep it open. And then using the drug therapy. We do a lot with aneurysmal disease. Mm-hmm. So vascular disease can cause narrowing. It can also cause swelling. So an aneurysm is a swelling of a blood vessel.
Right.
Indeed. The traditional way of treating aneurysms in the tummy, that's where they're commonest, is an open operation where the aneurysm is controlled. The blood going into the aneurysm is stopped with the clamp. The blood going out of the aneurysm into the legs are stopped with the clamp. And the aneurysm sac, this big balloon, this football is open, and a new graft cloth artery is stitched into place. I do a lot of that. In some patients, when the anatomy allows and is favorable, then these can be treated with placement of a stent. So minimally invasive keyhole surgery within vascular procedures done with the stents deployed from the groin arteries. So tiny punctures or cuts in the groin, and deploying the stent, patients can go home the same day or the next day. This has particularly revolutionized aneurysmal disease treatment in the chest. So in the thoracic aorta, because operating on the thoracic aorta is a lot more difficult, is associated with significantly greater risk of complications, particularly paraplegia.
Paraplegia, okay.
Yeah, the blood supply to the spine and the spinal cord comes from the thoracic aorta.
Right. Before we continue with this, are there any, signs or symptoms a person can understand that the person is developing an aneurysm?
No.
So how does a person realize that I need to get it checked? Or in what way can a person investigate about an aneurysm?
Yeah, so these are very sensible and relevant questions. Aneurysms rarely cause any symptoms.
Right.
In people who are slim, one may feel or see a beating, a pulse in the upper part of the tummy. Sometimes the inside lining of an aneurysm has got clot. That clot can break off and go into the legs, stop the blood to the leg. That's how an aneurysm is picked up. So the most common way of picking up an aneurysm is one has a scan of the tummy for some other reason. Exactly. And it is extremely common to go into hospital with bellyache and have an ultrasound scan or a CT scan.
So you mean to say a simple ultrasound can pick up an aneurysm?
And that is the principle of aneurysm screening. In the UK, we have aneurysm screening, men at the age of 65. We're not necessarily sexist. The reason it's offered to men only is because aneurysms affect men 4 times more common than they affect women.
Right.
When one has a family history of aneurysmal disease, that is quite significant. So people who, this condition runs in families and it affects people who smoke.
So possibly that the men smoke more and that is the reason?
Indeed. And that's been the case. In the United States, the Veterans Affairs program will screen high-risk individuals, so people who've had a family history, they've been smokers, etc. And again, men only. Denmark flirted with the idea of a screening program. The 2 most mature screening programs are Sweden and the UK. And what 10 years of screening has shown is it has reduced the incidence of a burst aneurysm, which is the thing that we want to avoid most.
It's a very often emergency, high emergency.
Well, it's death.
It's death.
Yeah. Very often, when the first presentation of an aneurysm is when they burst. They cause intense backache, intense bellyache, collapse, death. 50 out of 100 don't even make it into hospital. Of the ones who make it in, another 50 don't make it out. So you've got a condition that has a mortality of somewhere between 75 and 80%. Aneurysm screening, less cigarette smoking, reduces the risk of aneurysms, it reduces the risk of growth of aneurysms, and picks up much more. When I was a trainee, I would be doing a rupture once or twice a week. Today, they're once or twice a month. And that's the difference in the UK. We've dropped the incidence of aneurysm ruptures by over 2/3.
And that's the effect of screening.
Smoking, reduction, and screening.
Right. So now we have spoken about diabetes, we have spoken about varicose veins, we have spoken about aneurysm. But, you have said the program is being given to older people.
That's right.
So do you mean to say that, these kind of problems happen only in older people or even younger people can get affected with vascular problems?
Younger people do. I am in a minority. I treat children.
Children?
Yes, I treat young adults. And it's rare, but there are certain conditions, for example, Loeys-Dietz, Marfan syndrome, syndromic conditions that predispose patients to develop aneurysmal change.
So they are genetic conditions?
Genetic conditions. You're absolutely right.
Right.
Yes.
So that is how the younger people are getting
Younger people will get affected with aneurysmal disease. I do a lot of thoracic outlet surgery.
Okay.
This little space behind the collarbone, between the collarbone and the first rib, is a thoracic inlet, the outlet, depending upon which way you're looking. Glass half empty, glass half full. What comes out of that area is the blood vessel, the subclavian artery that goes into the arm. The brachial plexus, the nerves that come out from the side of the neck and are heading towards the arm.
Right.
And what goes back in is the subclavian vein. If one is born with an extra rib, cervical rib, prominent transverse process, that can often affect the nerves and the artery. If one has a previous fracture of a rib, or as I said previously, young people who do a lot of exercise and the arm goes up and down.
Right.
Trauma to the first rib or a clavicle fracture, etc. Then that can cause compression of the vein.
Okay.
If we all raise our arms, and we all have an MRI scan in this position, there is some natural compression of the subclavian vein in that space. Everyone will get it. But when there is a repetitive compression, damage to the inside of the vein, then those patients get it. Those young people, particularly young gym goers who do a lot of pressing, who develop a lot of muscle bulk very quickly,
right.
Please do not abuse steroids. There is just no justification for it. They only look attractive. There is no physical benefit to it.
Beyond a certain point, they don't even look attractive.
Exactly. But that's another whole story. And those patients will get a higher incidence of liver failure, significant mood disturbances, and higher incidence of vascular disease.
We're getting young people having higher incidence of heart diseases and dying of heart attacks.
That's exactly. It's exactly this very early atherosclerotic disease, which comes to the fore because their diets are unregulated, the exercise is either poor, they've used additives, they've abused drugs that they shouldn't be using, they smoke, they're in high-intensity jobs,
right.
They're chasing the money, it's heart attack and gone. And sadly, it's the families who are left to suffer.
Absolutely.
Yeah. So these are conditions, thoracic outlet, for example, that affects young people. In India, in particular, you see smoking-related vasospastic conditions.
I was just going to ask you that.
Yes, which are very prevalent. Ashkenazi Jews, for example. Indian population, for example. The classical thromboangiitis obliterans, Tau, Raynaud's, etc. Which is what we were taught.
Right.
From when we were in medical school, that was the only vascular disease known. It is a smoking-related vasospasm. It is extremely sensitive to the effect of nicotine.
Yes.
And classically on angiography, one sees a corkscrew pattern of blood vessels, collateral blood vessels, with the main blood vessels lost. And these patients get quite intense pain, fingers, toes, etc.
Yes.
The fundamental treatment for this condition is entirely nicotine cessation. And then other drugs such as iloprost, etc., which can open up or relax the musculature of blood vessels, the smooth muscle that's in blood vessels. And yes, blood vessels do have muscles as well.
Yes, they do. And yeah, drugs do help open up
these blood vessels.
But I think
traditional old drugs in India that are used, pentoxyphyllin, complete waste of time. Nitrofurantoin, waste of time. These drugs that were thought to make the RBCs a bit more flexible and stuff. No, these drugs do not cause your RBCs to suddenly take up yoga or Pilates.
You need to take up yoga and Pilates.
Indeed.
What I'm saying is the patient needs to take up.
Patients do.
Need to take up yoga and Pilates to avoid these kind of issues.
You're absolutely right.
Right.
Unless they don't have, they have the flexibility for brick wall.
You can anyway still improve your flexibility.
Correct.
Right.
Correct.
So, fine. I think we have spoken a lot about the most common things which my patients come across with problems to me. Now, I leave it to you, you tell us what other things as a vascular surgeon, if I've missed something, please tell me what other things vascular surgeons do.
Vascular surgeon Ghostbusters.
Ghostbusters, wow. That should be your tagline.
It is. It is.
Okay.
Who are you going to call?
Ghostbusters. Ghostbusters.
So, vascular surgeons really underpin services in hospitals. Whenever there is bleeding, who do you call? You call a vascular surgeon.
Right.
Yes. We assist and help a lot of surgical specialties. Obs and gynae. When there are gynae cancers in the pelvis, which have spread, which are close to or involving blood vessels, the vascular surgeon will come, help remove a tumor, replace a blood vessel if needed. Laparoscopic surgery in gynae is extremely common.
Yes.
Virtually all gynecological procedures.
Yes.
The use of a Verres needle is associated with arterial and venous injury.
Right.
Who comes to fix it? Vascular
surgeons.
That's right. We help and assist colleagues who undertake Whipple's procedures. You're familiar with pancreatic cancers, big operations. Those tumors, those cancers sometimes are quite adherent and quite stuck to the superior mesenteric vein, the portal vein, etc. Who are you going to call? A vascular surgeon. We would come in, we would replace a blood vessel, we would use vein from, one could use renal vein from the neck, or bovine pericardium, covering the lining of the heart of a cow. which is now commercially available to replace veins, or sections of veins, sections of arteries, etc., as a patch. You're familiar with the minimally invasive procedures in cardiology. So one of the things that's in the last 15 years changed cardiology practice is management of aortic stenosis. And traditionally it would be an open operation, removing a calcified diseased aortic valve, putting a new valve in. Today, it began with more the elderly patients with heart failure, with aortic stenosis and narrowed aortic valve were treated with essentially a new valve that was placed from the groin or from the subclavian artery through the blood vessels, jammed into the old valve and stretched open with a balloon. TAVI or TAVR, transcatheter aortic valve replacement or implantation. And vascular surgeons have been at the forefront, helping and working with their cardiology colleagues in getting access, repairing the damage to the blood vessels in the groin, and providing access through the arm, for example. Spinal surgery has changed a lot, particularly spinal surgery, where implants are placed within the spine. For scoliosis, twisty spines, patients bent over. All the surgery was done from the back. Modern techniques allow metal cages to be placed in the spine to straighten the spine. And it could be redo surgery or first-time surgery, and that can be done from the front. If it's 1 or 2 levels, they can approach the spine from the side. But my spinal colleagues and working with us have pioneered an anterior intravascular approach, where essentially you move the aorta, you move the vena cava and the iliac vessels, and you have direct access to the spine from the front. And that gives very good access, very good corrections, and it's a safe way for treating patients with spinal disorders. Some of the governance work that we have done with spinal surgical societies and our society, Vascular Surgical Society, are guidelines that require the presence of a vascular surgeon when spinal procedures are being undertaken, even in private hospitals. So vascular surgeons are essentially people who go in and help others. One of the other things I tend to do a lot of
What about trauma?
Fundamentally, all sort of penetrating trauma will inevitably involve vascular surgeons. Indeed. David Knott, my colleague from London, has pioneered vascular trauma, particularly in conflict zones. We are fortunate today that the areas we live have less conflict, but having grown up in India, seen the effects of the bomb blasts, having trained in Northern Ireland during the Troubles, punishment shootings, blast injuries, etc., all are essentially vascular injuries, and they require the presence of surgeons who are experienced in vascular surgical salvage procedures and techniques. So all of trauma is underpinned by vascular surgery. I treat patients with cancer. You may ask how. So kidney cancers going into the inferior vena cava, that's where they spread, require the help of a vascular surgeon to take tumors out of the IVC. Retroperitoneal sarcomas often involve blood vessels, the larger blood vessels, and certainly vascular surgical techniques for the use of a vascular surgeon is extremely important. And we do a lot of lines and forts. We use Forticats and Hickman lines to facilitate chemotherapy today in modern long-term chemotherapy, rather than the use of thick lines or peripheral access, which destroys veins very quickly. And one particular area I have an interest is in pediatric vascular access. So I do a lot of access in little children with hematological malignancies, with cystic fibrosis, and it is quite emotive dealing with tiny children.
Yes, it is.
One of the areas I haven't mentioned a lot that is renal failure. And vascular surgeons essentially provide life-saving vascular access procedures, AV fistulas, for patients with kidney failure. And that becomes their life insurance policy. That allows veins to mature, become thick-walled, have arterial flow in it, be able to stand with 2 needles 3 times a week for dialysis. And transplantation fundamentally is a vascular operation.
I want to ask you that. Organ transplant.
Organ transplantation is an offshoot of vascular surgery, frankly. It involves vascular surgical techniques. So one doesn't have to be a vascular surgeon, but one needs to be au fait, aware of vascular surgical techniques. Or be able to suture blood vessels. What is beautiful about vascular surgery is the intricacy, the delicacy that is that is required. And all these anastomoses need to be blood tight. They need to be watertight.
Absolutely.
So that's what makes vascular surgery so much more interesting. Also, to be a vascular surgeon, fundamentally, you have to be a doctor first.
Yes, of course.
And you go back to the reason why we became doctors. We saw a Hippocratic oath. We want to treat human beings.
Right.
We saw to do no further harm.
Yes.
And as a vascular surgeon, you have to think about all of those things. You have to think about medicine that we studied. You need to know respiratory medicine. You need to know cardiology. You need to know biochemistry. We talked about the Krebs cycle.
Yes.
Aerobic, anaerobic metabolism. You need to know renal medicine to be able to talk the same language as your renal physicians and your transplant nephrologists and your surgeons. You need to be able to converse with the cardiologists, the hepatologists, the respiratory consultants. They're extremely clever people. So having empathy towards your patients, respecting other specialties and colleagues, and leaving your ego at the front door of the hospital before you come in. Whenever you're called into theatre, and I get called a lot into theatre, you don't come in, criticize, shout, scream. You come in, they're calling you because they need you. They're calling you for help.
Right.
The most important person in that room is the one who's fast asleep on a very uncomfortable operating table.
Yes.
With lots of people around them, and an anaesthetist trying to keep them alive, and they're bleeding. What you want to be there is to help.
Stop the bleeding and help the patient.
Turn the tap off, save a life. That's the beauty of vascular surgery.
Well, Arun, that was really, really a fascinating conversation we had. And we learned so many things. It's not just about vascular surgery, but how important lifestyle factors are there, and in what way vascular surgeons, and in so many different ways, a vascular surgeon can help a patient. So thank you very much for coming for this talk.
Thank you.
And, I'm sure my viewers have learned a lot from this conversation. Thank you. Thank you so much.
Not at all. It's incredibly generous of you to invite me. Thank you.
Thank you.
And I wish all of you the very best.
And that wraps up our fascinating journey through the world of vascular surgery. I hope today's discussion has highlighted how crucial vascular health is to our well-being. Remember, your blood vessels are the lifelines that keep every part of your body functioning, from your brain to your toes. So taking care of them isn't just about aesthetics. It's about maintaining your quality of life and preventing serious complications. So if you have enjoyed the conversation today and found it helpful, be sure to subscribe to the Health Talk with Dr. Sagorika Malik for more such insightful discussions. You can follow us on Instagram, and remember, you can also catch this episode and more on Spotify or your favorite podcast app. The links are provided in the description. We would love to hear from you, as your feedback will help us to bring you the topics that matter most to you and your family. So until next time, stay informed and stay healthy, one episode at a time. Your health journey starts here.